an episode today of the current review. My name is Thamsanqa Tu, sometimes known as TT. I'm still with my brother Tebogo Kotsi from the Unsaid Podcast. And we're being joined by uh, somebody who's going to, shed light to us about what has been, topical news in the recent past or in the recent few days. The being signed into law of the National Health Insurance Act by the president last week. A lot of people have been asking questions, Dave Zahori. What exactly is this NHI? How are we going to benefit from it? Is it really something worth noting and celebrating as people? We've also seen that there are other people who are very much against the signing of this bill, but we won't be talking a lot of politics around it. I think we just need to get an understanding of what this bill is and what it means. In fact, it's an act now, no longer a bill, of what it is and what it means. And for this reason, we are joined by Dr. Sammy Mokoena. He's a specialist in community health, practicing here in the Free State. Ntate Mokoena, dumela.
Dumela Titi le Tebogo. Thank you for inviting me to your podcast. I truly appreciate it.
It's our pleasure. I mean, we're only happy to have you here because it will also help us a lot in terms of understanding what this thing is about. Because we're being mocked also on social media as lay people, who we're just saying NHI without understanding exactly what it is. Could you please just tell us, where does the idea come from, and is it something that you as a health practitioner in this country welcome, or is it something that you think should have been thought about differently?
Thank you so much, Titi, again. I think a very good question in terms of where it comes from, because I think sometimes that's where a lot of us miss this opportunity of interrogating where it comes from. So I think I must just, first outline where it comes from, not just on the national level, but I think also at the international level. And that as part of the SDG goals, which is Sustainable Development Goals, which have replaced the Millennium Development Goals or the MDG goals, but also is what is recommended by UN through the structure that I think by now we all know, WHO, World Health Organization. And the idea is around what we call universal health coverage. So the WHO encourages that every country must ensure that the concept of universal health coverage is implemented. And what is concept of universal health coverage? The concept of universal health coverage encompasses three things, TT. One is that everybody must have access to health, so population coverage, but also they must have basic access to all the necessary services. So it's expansion of service coverage. And the last part is that people must have these services covering all the population or most of the population without incurring financial loss. And so this is where this issue of NHI comes from. So South Africa, in implementing this concept of universal health coverage, decided on what we now called national health insurance.
And talking about you as an individual health practitioner, I just want to get your view on this one. Do you welcome the act itself, or are you one of those health practitioners that we have seen that have said that this thing is going to be a burden to the system as well as to themselves as individual health practitioners? What is your view on this?
Yeah, I think my personal view, and very important to say it's my personal view, that I welcome the act. TT, I think for me, it's long overdue. And my personal, if you ask why I welcome the act, is because I think it's about time that we realize that health is a human right. I think it's important that everybody have access to health services that they need, that are basic, quality health services without considering the socio-economic issues. Now health is a matter of money, and I think it's unfair that you can only access a health which is a human right when you have money. Is that it must be based on universal health coverage principle.
And before I hand over to David to ask like a few more questions, you are saying that it's about universal health coverage, making sure that people have access to to health. Isn't that is what is already happening in this country, because there are clinics, there are public hospitals which our people have access to, and they're not paying any services for it. I've heard that being the argument actually being made, that why therefore do you want to expand this to mean that people will have access to all other health facilities except for these ones that they have access to?
Yeah, a very good question again, Titi, because I think maybe that's where also the misunderstanding comes. The health services that we have currently covers 85% of the population are relying on 15% of the available funding. While when you look at the other side in private, that they are covering 15% with more or less 15% of the population with more money than we have in the public. So as a result, you find that the health services are extremely constrained, and everybody complains about this. Long queues at the clinics, shortage of staff, poor infrastructure, and all of that. And if we were to make these services available to all of us, we really need to look at this concept of NHI. And let me make an example to just illustrate what my issue is. If you are in Helebron, which is where I worked, and you happen to have an accident, you are around that area, you have a hospital there, a small hospital, district hospital called Tokolo District Hospital. And Tokolo Hospital, because of its size, there are certain things that you won't have. So if you have a very bad injury, you won't find the CT scan, and sometimes you won't even find the X-ray if you come on the weekend or if you come at night. But if you go down the road, Mfuleni Private Hospital, and I'm making an example, you find that a person with a headache or with flu would get the same services, CT scan just for, headache, just for, while you who really need the service won't be able to have the access to such. I think it's unfair. And I think it's a serious inequality in healthcare that I think we cannot justify any longer. For me, I think it's a matter of really dealing with health inequalities that we have in our nation. While we talk about economic inequalities, but I think we should not apply the same measure when it comes to health. I cannot accept that my grandmother can only have access to the basic health services based on money. I don't think that we should accept such a concept. I think we really need to look into how we make sure that services are acceptable or are accessible to everyone.
Okay. Tebza?
Titi, thanks, Titi. Quick one. For the first time, I'm gonna agree with what the doctor is saying, because I actually did my homework around the bill itself, the new, and to be honest, it's something that I've been speaking about, to say there's so much segregation, especially economic segregation amongst us as South African. So if there is a bill that can actually cater even for the poorest of the poor to actually get medical assistance from a private hospital, why not? It's something that we can all agree to. The only thing that we are actually experiencing right now, it's the negative narrative from private sector that is actually not actually looking into the benefits in terms of this. Because why am I saying so? If you can think about it, healthcare should be accessible to everyone. anyone should be able to access healthcare at any given point. But now, I'm talking from experience, whereby when you didn't have a medical aid and you get to be dropped off at the private hospital, you'll be told, take him to a government hospital because he cannot afford us. But now, what happens if the patient is actually critical and that critical person has to be treated? And I used to argue with the hospital where I used to say to them, at least stabilize the person to that extent that at least he can be transferred. But they would refuse it, to say he doesn't have a medical aid, we can't cover him. He has to go in the same condition. So with this new bill that is actually saying any person can be treated anywhere, honestly speaking, there's nothing much that one can say, but to actually say this is a good thing to come from South Africa. And the only thing that I would actually say is that it should be implemented right. It shouldn't be utilized as let's get the rich quick scheme. But if it's implemented right, it will actually help and reduce the burden on the public sector, because majority of people who cannot afford to go to the private sector, they end up in the public sector, and it's just too much influx that cannot be carried. So honestly speaking, my opinion, I give it a thumbs up, TT.
Oh yeah, and I think just talking about that, there is a case which happened, I think just last week, of a mother who had to take her child to a hospital in Bloemfontein, leaving Paris. She had to get onto a, what do you call this thing, like a Haitian transport system at 2 a.m. in the morning, going for a service that will be performed after 8 a.m. in Bloemfontein. Now, she has to leave this early because this public transport system that they are using has to collect people from a number of points. And then she gets there. She is returned back because the doctors which scheduled the appointment got the dates wrong. Never mind that. Maybe that is not important. But the important thing is this, that she had to go 300 kilometers away from where she is, whereas she could have gotten a similar service at the hospital, maybe a public hospital, which has the facilities that she went there for, just 45 kilometers away. That is the problem. Now, Dr. Mokoena, please tell me, who does this NHI Act cover? Who exactly is covered? Does it cover everybody? Because there are also questions about that. Is that, can I qualify? Like, say somebody who's unemployed, do they qualify to be covered by this particular act? And what does one need to do in order to be covered? Dr. Mokoena, I think you have muted your mic.
Okay, thank you. Am I audible now?
You are.
Okay, thank you so much. So there are several people who the act envisaged to cover, and first, I think the act it will cover all the South Africans, obviously, who are registered with their as citizens, but also it will cover all the people who are refugees, meaning that they are legal foreign in our country, and also it will cover everyone, obviously, as the act will probably explain later in terms of when it comes to regulation. But in general, it covers all South Africans. So whether you have a medical aid or not medical aid, you will be covered. Whether if you are a refugee, meaning that you are recognized in this country, whether you are now a citizen of South Africa, you will be covered under the act. People who are excluded from this are illegal foreigners, and obviously they will be able to receive your emergency, because we can't turn away anyone coming with an emergency. But in terms of the general services that are offered, the packages or the benefits, they won't benefit. Anyone who is visiting our country won't be covered, because they are supposed to be covered by the insurance when they come and visit our country. And in terms of age groups, it covers all the age group, it covers all the races, it covers all the economic levels. So it covers from the president up to the men on the streets. As long as they are South Africans with proper documentations, they will be covered by the act.
And when does coverage of this act actually begin? Is it already operational, or there are systems still to be set up in place, for it to be actually operational?
Yeah, I think also that's very important, because sometimes I think the big sort of issues that are coming is because people are envisaging that with the signing of the act is already operational. But we know that with any act, before it can be fully implemented, there are regulations that will be done. For an example, regulation will tell us how the benefits are going to function. The regulations will tell us which services package will be implemented. So at the moment, the act has been approved. So there are regulations that are already, I think, being worked on, that will be presented in explaining in details how some of the issues that usually people ask about, for example, what services will this cover, which facilities, the registration, because everybody must register under NHI, how that will function, which systems are going to be implemented. So while the act has been signed into law, there are still systems that are being put in place. So it does not mean you can go to a private hospital today and present yourself and say you are sick and use the NHI Act as a reason, because there are still bilaterals, MOU, SLAs that needs to be signed in terms of how the payments will be made and all of that. But the important part is that now that the Act has been in place, it allows the decision makers, the planners, to now start continuing with the process, because we could not engage private, you could not engage the service providers with before you could have an act in place, because the act is just a framework. But in terms of the implementation, the regulations will be able to explain, to give more clarification.
When do you think that we will be ready to have these regulations in place, and when will it actually, be operational? By when do you think this will happen?
Yeah, I think it's a bit difficult to explain, and let me tell you why. It's because obviously, as you would have seen, and why probably we're having this discussion, is that there is a lot of opposition in terms of, and here I'm not talking just political, I'm talking in general. There's a lot of people who are pushing back in terms of this being implemented. So we expect that there'll be challenges, in courts and all of that. So that might actually prolong the real implementation. But I think the initial part was envisaged that it will be completed by 2028 at least, and then the full implementation probably in my just knowledge, probably it will take 10 years from now. I mean, the full implementation. But I'm saying the initial sort of starting of the framework, 2028 was envisaged. And maybe before I go, let me maybe make your viewers aware, and also you're aware of that this process, we had already started with NHI what we call a pilot project. And one of those, let me make an example, is that as government, we are able to purchase services from doctors. I have an example in Tebogo, I have an example in Faisal Dabi, I have an example in Kharib here in the Free State, where doctors would come to the clinic and see patients and be paid for their services, meaning that we as government are purchasers of services. And it's not just doctors, even other services, rehabilitation services, nursing care, maternity. This has already been implemented and is still ongoing. So it's not the first time when the act now is implemented that will be starting to. We had already started, so there are work that had already started in terms of the NHI, and there were various models that were being tested in terms of how can we provide these services. Should the patients go to the private practitioner or the practitioner come to us, or should we have both models and all of that? So that has long been done, TT. It's been an ongoing project for quite a while.
Now, in terms of this pilot that you ran in the Free State, I hear you more saying that you ran it in public facilities where you took private doctors and private practitioners into these public places to go and perform these services, and they were paid for these services. Now, have you had a situation where you would refer public patients to private institutions and the government would pay for these private institutions?
Yes, Titi, we have had, and actually it's been a situation that has been sort of in operation for quite a while. I work as a manager in one of the facilities here in the Free State, and recently, if I don't have, for an example, an ICU bed in a public hospital, and I have a patient who's critical who needs a ICU bed, and I can't find it in any of the facilities that we have within the Free State with necessary skill, there's already an arrangement that I discussed with my counterpart in the private sector, in the private hospital, to admit some of those patients, and we pay them the fees and services. And this is not just the Free State unique situation, it's happening from all over the country. The other example is, for an example, in the Free State, you would not have some of the children's heart services. So we refer patients to Cape Town, we refer the patients to Gauteng. I have patients who I accept from Northern Cape because of the services that they do not have. During COVID, it was even at a wider scale. I could accept a patient from Eastern Cape, I could accept a patient from any area, because either they don't have the facilities or they don't have the skills, and which we know there are some specialties where skills are really rare, and as a result you are forced to, if you like, outsource the skill for the benefit of the patient. I had a patient recently who needed a liver transplant. We don't do liver transplant currently in the Free State, so that patient was transferred to Gauteng to receive those facilities, and the government paid. So it's something that has been in operational. The difference with NHI is that if the government is a sole purchaser of services, we are able to negotiate prices. At the moment, it's a bit difficult to negotiate prices. So you go to GP X, wants this much money. You go to private hospital X, they want this much money. But if with the bulk buying, I'm able to negotiate prices better, and we make it sort of equitable and standard across the country, so that if Gauteng does not want more money, while Northern Cape want less money. So I think that's advantage with NHI, with the government being the sole purchaser of healthcare services.
Now, tell me, does this now NHI sort of put out of business the private healthcare medical aid schemes, for example? Does it mean that I, as an individual person, do not need anymore to go, to pay for a medical aid scheme? I must just do away with that and keep my money in my own pocket and no longer pay for health services. Okay.
So in terms of your medical aid, the facility, the way NHI is envisaged to function, and I want us to have this open mind, TT, as we discussed, that the idea is around universal coverage. So we want to make sure that the population is covered, receiving all the services without incurring financial loss, right? So the idea is that all the basic services, for an example, primary healthcare services, which is usually the services that you would find at the clinics, that should be accessible to everyone, irrespective of whether they have money or not. Or all the emergency procedures or emergency treatment would be accessible to everyone without them having to incur financial loss, right? So with that in mind, obviously, there will be benefit in terms of package of services that will be offered under NHI, right? So NHI is not going to cover all the services. I always make this example to say, if a person wants to have a cosmetic surgery, maybe they want to move the nose, make it sharper or what, NHI won't cover that, because that's not a necessary service. That's not a basic service. That's not a primary healthcare services. For an example, if you want to have, dentures, NHI won't cover that, because that's a personal, more cosmetic issue, unless if there are other deformities. So obviously, with that implementation, ultimately, TT, what we'll find is that when NHI starts implementing these basic benefits and services, they would not be covered anymore by the medical aids. But there will be other services that medical aid will still be able to cover, right? But the other issue that we must understand is that currently the medical aids themselves are finding the cost of healthcare extremely high. Why am I saying so? I'm a member of the medical aid, and I'm not ashamed to say that. But what I'm saying is, you find that by June, July, it started November, you find that your money is finished. Now you start paying out of your pocket. Now it's almost June, July, you find that the benefits that the medical aid are able to pay for you are already finished or run dry. What happens when the money runs? You come to the public health services, which is already congested, as I say. So it means even the medical aids themselves are unable to cope with the cost of healthcare. And that's why NHI will assist us to at least make sure that we cover the basic services, right? And those that are really needed by the people, when through the government being the sole purchaser, so that you can have an ability to at least standardize the prices that you can have across. But those services that you still want extra, and I'm sure there will be many, medical aid would be allowed to cover such.
And how exactly is this fund going to be funded? I'm thinking one of the examples would be to say the users themselves, people who are employed, who have medical aid fund, like private medical aid, would have an option to pay their medical aid funds directly into the NHI in order to fund this service? Or is it going to be by way of introducing a new tax, like an NHI tax, or how is it going to happen?
Yeah, I think the final details are still not clear, but not clear because there's no idea. Clear because there still need to be finalization around it. Remember, I said you could not proceed before the act could be signed, because you would not have a legal basis of why you do this. But the few suggestions that has been outlined and explained. One, already, as you mentioned, people with medical aid like myself, there is a contribution that the government is giving to my medical aid, and the contribution that I'm putting in as a person who's benefiting. So those contributions, so the money is already there, but the money is scattered all over. So those contributions form part of what NHI will be done. The other contribution is your rebate, your tax rebate. You know that we always claim, those who have medical aid claim for tax, or in terms of SARS, in terms of the rebates. That money will also be put in the kitty of NHI. There is also subsidies that government also gives to medical aid schemes that the government is able. And when those money are put together, TT, and we sort of have an estimation of how much money we have, that's when then the decision in terms of possible NHI tax could be considered. But that is not a definite fact as things stand at the moment.
Okay. Dr. Mokoena, I think you have helped to bring the light to many of us as to what in the basic form this actually means, this act. And I feel like there is a lot more that we can uncover for me and you and a lot of other people. So I want us to have this conversation ongoing at another time. But I want to thank you very much. I think you have done quite well in explaining what this act means in its basic form. And at the later stage, maybe you may be able to uncover even more information for most of us. In that regard, if there is nothing else that you would like to add, perhaps I would like to thank you. Is there anything else you'd like to add, for our benefit?
Definitely, TT, and I'm open to further discussions because I think we've just scraped the surface. But
Yes.
what I want to emphasize, and as a take-home message here, is that health is supposed to be a human right. Health must not be determined by your socioeconomic status. I think it will be a sorry state if we as a country allow that you can access health based on your finances. We know the ramifications. If we agree that our country is going through such high unemployment and so forth, we are basically admitting that majority of our people won't have the healthcare that they need, that is necessary. And I think it's on that basis that we should make universal health coverage a human right.
Dr. Mokoena, thank you very much for your time, and we appreciate every bit of information that we're getting on this important health issue. We are out, and we will be back again at 3 o'clock with the next session.